Hi, everyone. I'm Lilit Mnatsakanyan. I'm an associate clinical professor of neurology at the University of California, Irvine. I will be discussing headache diagnosis and management, and also some differential relevant to the facial pain. I have no disclosures. We'll start with understanding what are the structures that are involved in a facial pain. There's neurological, such as cranial nerves, musculoskeletal, and vascular structures that could be contributing to the pain. In 2020, a new subspecialty or new area of focus came out for orofacial pain subspecialty, and they came up with the international classification of orofacial pain, their first edition, which is highly modeling the ICHD, International Classification of Headache Disorders. And these are the following categories defined. Orofacial pain attributed to the disorders of dental-alveolar and anatomically related structures, myofascial pain, temporomandibular joint pain, orofacial pain attributed to the lesion related to the cranial nerves, pain resembling presentations of primary headaches, as well as idiopathic orofacial pain. So orofacial pain is basically attributed, defined as caused by diseases or injuries or abnormal functioning of the pulp, periodontal, oral mucosa, salivary glands. Typically, this is a dull, aching, throbbing sensation pain that can go anywhere from mild tenderness, soreness to excruciating, intolerable intensity. This is a table just for the reference for our dental colleagues to go through the updated diagnosis and treatment options for pulpitis, periodontal, cracked tooth, dentinal pain. Moving on the next category is myofascial pain, which is typically dull, achy. It's all over the head, neck, or parts, could include shoulders or all facial region. The main differentiation of this pain from other disorders is it does not follow specific neurological structure. So it's not limited to a dermatome, to myotome, it's more vague. Can be triggered by stress, oral habits, poor sleep, depression. Some of the trigger point includes tendons, muscles, and then there's the pathophysiology is poorly understood, but considered to be muscle contraction, ischemia. Some of the muscles that are commonly involved are trapezius, suboccipital, posterior neck muscles. Treatment is largely nonspecific. It includes pain, nonsteroidal agents, muscle relaxants, physical therapy, massage therapies, cognitive behavioral therapies, stress reduction techniques, stretching exercises. Moving on to the temporomandibular disorders, this is a pain that is typically precipitated by joint movement or chewing. There could be inflammation, there could be discondyle discorneation, microtrauma, behavioral influences, and symptoms also include pain with mastication, such as chewing again, ear ache, jaw ache, and other facial regions. The good news is that this disorder is self-limiting because fibrocartilaginous structures can remodel. If the treatment is really necessary, it starts with the patient education, which is avoiding chewy foods, avoiding clenching jaw, and then applying heat or ice, and a soft diet. From the pharmacological therapy perspective, again, non-specific non-steroidal agents, muscle relaxants, at times trigger point injections or specific joint injections can help. From the non-pharmacological therapies, we have stabilization splints, physical therapies, and behavioral therapies. One other category is the idiopathic facial pain, which is based on the International Headache Society's classification. It's a pain that's lasting over 2 hours for a 3-month period. It's poorly localized. It does not follow any specific distribution of a nerve. It's dull, achy, nagging quality. Typically, the neurological exam is normal and dental cause has been ruled out by appropriate investigations and management. Now, there's a large list of cranial nerve disorders that could mimic or are included in the facial pain categories. The common one, though rare, is trigeminal neuralgia, which is a unique type of shock-like electrical shock, shooting, stabbing pain that occurs in recurrent paroxysms. It's one-sided, follows the trigeminal nerve distribution. One of the branches, most common branch being V1. It lasts a really short, a few seconds or a minute, and it can be precipitated by inactive stimuli within the affected nerve distribution. It is essential to determine whether this is a primary neuralgia or it has secondary causes, because secondary causes will have specific disease categories that need to be addressed and treated specifically. From symptomatic management, the first management is really anti-seizure drugs with carbamazepine having level A evidence. That means it has established efficacy, followed by oxcarbazepine, that is level B, which is considered to be probably effective. And then there is many other medications that have level C, possibly effective or undefined categories, mainly including baclofen, lamotrigine, on the other anti-seizure medications such as phenytoin, valproic acid, gabapentin, pregabalin. Now, for more definite management, when the medication management fails, the Botox therapy can be tried, but there's also invasive procedures such as radiotherapies, ablation therapies, and a microvascular decompression of the nerve if there is identified conflict with the vessel at the root entry zone in the brainstem. One other neuralgia is the nervus intermedius neuralgia, which it's a branch of a facial nerve. Again, very unique paroxysmal attacks of short-lasting, very severe pain that is around the ear, can be stimulated in a posterior wall of the outer tricuminal or periocular region if just little stimulus applied there. It is important to differentiate between oral facial pain and primary headache disorders because incorrect diagnosis may lead to irreversible dental procedures or delay appropriate management from primary headaches. Headaches are the most common symptom that the neurologists evaluate. There's about 3 billion people that have headache disorders. Of those, close to 1.9 billion will have tension type headache, and over 1 billion will have migraine type headaches. So tension type headache is the most common primary headache disorder in general population. However, what brings people to the physician is the migraine. So the most common headache type that clinicians see is the migraine. That said, very substantial proportion of the patients with migraine do not receive accurate diagnosis. Again, moving on to the classification, we have 4 groups of primary headache types. Migraine being the most common, as discussed, along with also tension type headaches. And then there's a group of disorder called trigeminal autonomic cephalalgias, and number of headache disorders that are for example, cough or exercise-induced headaches. In the essence of time, I won't be discussing the trigeminal autonomic cephalalgias and primary headache disorders much today. So secondary causes of headaches may very resemble the migraine or tension type or trigeminal autonomic cephalalgias. Therefore, it is important to remember and be familiar with warning signs of these headaches. And some of the red flags or warning signs are anytime there is the first and the worst headache, or if the headache has abrupt onset. Progression of a typical headache. So if someone has a lifelong history of tension type headaches, it doesn't mean they may not get a tumor or stroke or anything else that could cause additional issues. If the headache is the new onset in children less than 5-year-old and older than 50-year-old, anytime there's new headache with people who have cancer, who are on immunosuppression for a variety of the reason, in pregnancy, headaches when there is associated new neurological problems such as seizure or syncope, headaches that are triggered by Valsalva maneuvers. And then when the neurological symptoms persist and neurological exam is abnormal. This is a table going through more details into secondary causes of the headaches. So we're looking for systemic problems like fever, night sweats, any new neurological signs, confusions, vocal deficits, problems speaking, weakness, all those could point to the intracranial lesion, mass lesion. And then when it's a very sudden, very severe thunderclap headache, certain diagnoses need to be ruled out. When the headaches change with the position, that needs additional attention. Pregnancy, postpartum, and induced precipitated by Valsalva maneuver all need additional attention. For thunderclap headaches, it's absolutely important to rule out vascular problems such as intracranial bleeding, mainly subarachnoid hemorrhage, from aneurysmal rupture, or vessel dissection or sinus thrombosis, which could be devastating and carry high mortality, and some other non-vascular causes that need to be considered. So how do we evaluate for headaches? It starts with the important history. It's the most important aspect for the headache evaluation. Brain MRI is the imaging of choice because it allows us to have more detailed anatomy of intracranial structures, look for neurovascular causes for headaches. Head CT is a quick way to rule out something major, such as skull fracture or bleeding or large mass lesion, but it's not sensitive to more smaller structural lesions. In obtaining the headache history, it's important to pay attention to the type, quality of the pain, the frequency, duration, location of the pain, and any associated factors, along with the main pain symptom. So once again, the three most major categories of primary headaches are migraine, tension type, and trigeminal autonomic cephalalgias. And over 70% of migraine patients will present to the primary care first before seeing a neurologist. Therefore, it is essential for the primary care providers to be well familiar with this diagnosis and have proper referral pattern as it fits. So there's migraine with aura and without aura. Just a reminder is that aura is a warning prodrome sign, and based on international classification for migraine without aura, the pain with migraine is unilateral, it's pulsatile or throbbing quality, it has moderate and severe intensity, and it could be aggravated by or caused by routine physical activity. Typically, the pain lasts anywhere from 4 to 72 hours, and we need 5 of this type of pain attacks in order to classify the pain as migraine. In addition, there should be at least one of the associated symptoms, such as nausea, vomiting, photophobia, or phonophobia. Now there's migraine with aura, that is in addition to the symptoms we discussed, there is a warning of either visual, common, for example, being zigzag lines, or sensory or speech problems, etc. And for a chronic migraine category, basically there is 15 days a month that the similar pain occurs. So migraine pathophysiology is quite complex and not very well understood, but from we do know by now is considered a problem of dysfunctional network connectivity. It's a central genetically determined, genetically inherited disorder. And the main structures that are involved in migraine pathophysiology is different parts of cerebral hemisphere and brainstem, in addition to dura and vessels, based on the trigeminovascular system and its network connectivity. 1 in 16 men will have migraine, 1 in 5 women have migraine, 1 in 11 children, over 1 billion worldwide, and 38 million in the United States living with migraine. And it's important to recognize this is one of the common cause of disability in a younger population, the prevalence being during working years, anywhere between 25 to 55-year-old. So essentially diagnosis and approach to treatment is very important. And approaching the treatment starts with understanding, is this episodic migraine with only acute attacks, or we're dealing with a more chronic migraine with the need for preventive therapy. So the therapy is divided into abortive therapy, that could be pharmacological therapies, and then non-pharmacological therapies, and then preventive therapies that can include both, also again pharmacological therapies and non-pharmacological therapies. As a reminder, from non-pharmacological therapies, it is important to pay attention or counsel about adequate sleep, resting in a dark, quiet space, hydration, using ice pack, ice hat, ice helmet. And there's few creams like containing menthol, camphor, lidocaine, or essential oils that can help. Deep breathing, guided meditation, biofeedback, which need to be having training before the actual attack. Looking into pharmacological treatment for the migraine, again, we have large number of medications with divided by categories: non-specific treatment for migraines and more specific therapies for migraine headaches. Out of non-specific therapies, the acetaminophen has level A evidence, meaning again there's strong evidence that it's effective during acute attack. And then non-steroidal anti-inflammatory agents such as aspirin, diclofenac, ibuprofen, naproxen all have level A evidence. Then we have migraine-specific therapies under group triptans. There is 7 triptans available, all having strong level A evidence. Then another group of medication called dihydroergotamine, which comes in nasal and IV formulations, all with the level A evidence. Then we have some with level B, meaning possibly effective. Again, the IV for dihydroergotamine, tramadol, and no really or very weak evidence for codeine. The other category that's important to pay attention to, antiemetics with level B. I mentioned that nausea, vomiting is part of the migraine symptomatology. In addition, some data is known that it can help headaches as well, specifically the metoclopramide, prochlorperazine. These are the 7 triptans available in variety of formulations, oral or intranasal or subcutaneously. Basically, the key in using triptans is to use early into the headache symptoms, at the onset of the symptoms, in order to be maximally effective. Most of the triptans have early onset and shorter Tmax, versus the 2 of the triptans, the naratriptan and frovatriptan. They have the longer Tmax, and they can be used in longer attacks with the risk of more recurrence and low risk of the side effects. So the triptans, they are a 5-HT serotonin agonists, specifically acting on 1BD receptor. Some of them have 5-HT1F receptor specific mechanism for the migraine treatment. There's common side effects as with any medications. It could be nausea, dizziness, somnolence, paresthesia, sometimes chest tightness, flushing, filling of the throat, heaviness. This group of medications is limited in people who have uncontrolled hypertension, peripheral vascular disease, coronary artery disease, stroke, cardiac arrhythmias, ischemic bowel disease, hemiplegic migraines. There is really insufficient data in people who are older 65-year-old. The good news is that there has been historical concerns with triptans, for example, for serotonin syndrome. However, it's now known that there is not significant risk if it's combined with SSRIs or SNRIs or contraceptives. The 2015 meta-analysis concluded that triptans provide 2-hour pain relief for 42 to 76% of patients, and they're equal or better than non-steroidal anti-inflammatory agents in up to 52% of cases. So we'll start with a case, a 60-year-old female who has migraines in her young 20s. Not that frequent, however, about once or twice per month, but they can be very disabling, limiting the day and basically making her bedbound. She's initially tried non-steroidal agents, but they did not help. But then she achieved good control with sumatriptan as needed for her acute headache attacks. Unfortunately, more recently, she suffered myocardial infarction and she went back to see her primary care physician, who told her that she no longer can use sumatriptan because it's now contraindicated with her coronary artery disease. And she's asking the question what she can do because previous other treatments fails. So for a patient like this, we have emerging therapies in a migraine. These are basically specific treatments targeted CGRP, calcitonin gene-related peptide, which has been long known to play a role in migraine pathophysiology. Over 20 years, there have been a lot of research interest in focusing on migraine-specific therapies. And 2019 is the first FDA-approved medication came out called ubrogepant, Ubrelvy, that was approved for acute therapy. These are small molecules CGRP receptor antagonism under the name of gepants. And then subsequently, other additional 3 came out, rimegepant, atogepant, and zavegepant, which is the last to get FDA approval in April of this year, 2023. And it's unique that it has intranasal formulation. These medications can be taken during the acute migraine attack. 2 of them are also received approval to use for preventive treatment. So this is the secret code, Ubrelvy, for the review and the slides and receiving in CME later on. Moving on to discussing the calcitonin gene-related peptide, as I mentioned already, it's a neuropeptide that is been heavily known to be involved in migraine pathophysiology. It has large effects on both peripheral nervous system as well as CNS, central nervous system. For the peripheral nervous system, it causes vasodilation, mast cell degranulation. In CNS, it can cause pain modulation and central sensitization. And now with the gepant availability, of course, there hasn't been a long time to show established efficacy, but a specific level category of efficiency, but it is established efficacy for gepants. CGRP receptor antagonists. And then there is other new category medication also available under DTANs, namely lasmiditan, which comes in 3 dosage formulation, again approved for during acute attack. The DTANs are novel category acute migraine management. They are also selective about 5-HT1F serotonin receptor agonists. The common side effects include dizziness, fatigue, paresthesia, sedation. And the important restriction is a driving restriction for 8 hours and also medication overuse potential. It is also important to mention, I went through different categories of available evidence for the acute migraine therapies, but it is important to make a point that any type of opioid medications are not recommended for migraine treatments because they have not shown to have any established efficacy. So question for the clinicians comes up, okay, we have all these new therapies available. Now, what do we do? How do we pick or individualize the therapies? So current recommendation from American Headache Society Association, as well as AEN, American Neurological Association, is the 2 triptans that are, if someone has tried 2 triptans and it did not show any efficacy, or the patient had side effects, or like our patient, they had contraindication to standard therapy. In our case, the triptan was working, but there was a contraindication in using it. So 2 failed triptans or side effects or contraindications. Additional emerging a group of therapies that are non-pharmacological that received FDA clearance anywhere between 2017 to 2021 are a number of devices, neuromodulation devices. And these are transmagnetic stimulation, the trigeminal nerve stimulation, vagal nerve stimulation, remote electrical neuromodulation, and then combined external occipital and trigeminal nerve stimulation. All of these medications have received approval for acute migraine attack, and TNS, which is trigeminal nerve stimulation, and remote electrical nerve stimulation have received approval also for preventive therapies. These are good options for people who prefer to use non-pharmacological treatments or any other situations when pharmacological treatment is either not desired or contraindicated in acute attacks. The limitation with these devices has been that they are expensive, somewhere around $400 category, and it's hard to get insurance approval otherwise. Moving on to next portion of the migraine treatment, which is preventive therapies. When do we approach for preventive therapies? Basically, if someone suffers more than 15 days a month with migraine. However, in people who have disabling headaches, much less frequency, but disabling headaches, or there's a lot of days that are basically out of work or unable to tolerate their routine activities because of the headache, those could qualify for preventive therapies. So again, for first discussing pharmacological therapies for the prevention, we have cognitive behavioral therapies of biofeedback, relaxation training, regular aerobic exercise, sleep, and then nutrition and hydration are all extremely important for migraine prevention. From the pharmacological therapies, again, we have since 2012 a lot of AAN, American Academy of Neurology, and American Headache Society approved guidelines with to categorize preventive therapies. There is anti-seizure medications, there is antidepressants, and other category of medications that help beta blockers. So the medications that have level A confirmed efficacy is Depakote, one of the anti-seizure medications, as well as topiramate, which is also anti or seizure medication. Both have level A evidence for migraine prevention. Basically, that means these are medications that will be taken daily, sometimes twice a day, in order to prevent the frequency, reduce the frequency and of the headache days, and also ideally become pain-free over a longer period of time. I mentioned that migraine is common in women and young women, and unfortunately, both, for example, these medications have are category D for pregnancy. That means there is no harm to the fetus. With a variety of specific malformations that we're looking into. However, this could be limitations. In addition, for example, with valproic acid, there is the risk of thrombocytopenia, hepatic dysfunction, pancreatitis, and for Topamax, it cannot be used with nephrolithiasis. It can cause weight loss, which could be desirable or not. And then moving on, the next category that have level A evidence is the beta blockers, with propranolol being more commonly used, but it has limitations in people who have asthma. It can worsen this depression. Metoprolol is more cardioselective, so it can be used in, or should not worsen the asthma. And then there is onabotulinum toxin, Botox injections for that are approved for chronic migraine therapies. Next category is antidepressants, with amitriptyline having level B efficacy for migraine therapy. So is venlafaxine, another antidepressant. And then this is followed by large number of medications that include candesartan, lisinopril, gabapentin, verapamil, memantine, duloxetine. All of these medications have either C or not well-established efficacy. They're still useful options for select individuals who have contraindications or other situations when the earlier mentioned medications are not easy to use. And here in chronic migraine management, preventive management, we again have the emerging new therapies. Again, under GPANs, this is the same table I showed earlier, with availability of 2-GPAN, rimegepant, which is Nurtec, and atogepant, Calypta for preventive therapies. Both are oral therapies approved in 2020 and 2021. And then we have 4 new medications. These are CGRP monoclonal antibodies that are specifically approved for preventive therapies in 2018 and 2020. The first medication that received approval was aranumab Aimovig, which is available for monthly subcutaneous injection. Fremanezumab, again, subcutaneous injection, galcanezumab, which it could be monthly injection subcutaneously, and then the fourth one that got approval in 2020, eptinezumab, which is available IV, and it's injectable every 3 months. So what is the advantage, again, for this new group of medications, the CGRP monoclonal antibodies? So they showed high 50% responder rate. Basically, over 60% of people showed 50% or more headache reduction. Other advantages were that these medications had faster onset, faster efficacy, a robust efficacy, and then potentially lower side effect burden. So even though the pilot trial showed less side effects, and then post-approval period showed a little bit higher percentage of the side effects, but overall, as a group, it has lower side effect burden. And they're convenient in the way they're administered. It's injections, and monthly or quarterly. Another unique feature of these medications is that they do not have a lot of drug-to-drug interactions. So it's mostly safe to use in polypharmacy. It also can be combined with onabotulinum toxin A, with, in fact, some studies focusing on that they may have actually Botox and CGRP monoclonal antibodies may have some synergistic effects. It is harder to get an approval for both through the insurance. However, they are known to be effective. In talking or getting ourselves familiar with some of the side effects, this includes constipation with the first medication, Aranumab by Movic, that came out with up to 43% rate of constipation. Constipation could be severe at times. And then the newer label came up for hypertension watch, which is typically the first week of the medication use. The common side effects include dizziness, fatigue, cramps, joint pain, nausea, worsening headaches. And then other issue that may come up with this medication is early wearing off. Basically, by the time it's the time for the next injection, the symptoms may, the effect may wear off. Caution is advised with Raynaud's phenomenon. And there's not too much known about the pregnancy with this group of medications. Currently, it is advised that women who are planning pregnancy, they should wait 5 months after the last dose of the medication to conceive. Again, we have some guidance on when to begin CGRP monoclonal antibodies. So current guideline recommendation is that if there's inability to tolerate or inadequate response to a 6-week trial of 2 or more level A or B treatment. So if someone has tried and failed topiramate, valproic acid, propranolol, amitriptyline, 2 of this or more, then based on the American Headache Association consensus, then can be recommended to use CGRP monoclonal antibodies for prevention. How do we choose medications in general for preventive therapies? It is important to pay attention to comorbidities. Are they overweight, or are there cachectic, depression, insomnia, vascular risk factors, GI side effects, etc. And then contraindications, safety profile need to be considered each time we add a new medication to another list of medications that people are on. And then how fast we want the effect to see. Do we want to have very rapid at the onset or more sustained prevention of the pain? A little bit just a reminder that there is also another group of agents available, nutritional herbal agents for preventive therapies. This have somewhat evidence, not very strong evidence, but magnesium in combination with riboflavin as an option. Typically has to try about 3 months before one can see specific efficacy or not. Feverfew, which is not recommended in pregnancy, and this is mentioned because it's considered herbal. And then coenzyme Q. Butterbar also was available, but currently it is not recommended by American Headache Association because of a higher risk of hepatotoxicity. Couple words about the situation when patients with a more sustained or refractory headaches have to come into the emergency department to receive escalated therapy. In these situations, typically, again, nausea and vomiting being a common symptom with the migraine. It is important to approach or apply to more non-oral agents, so injectable, subcutaneous, or IV. Sumatriptan, if it's still early in the headache stage, is available an option to try. If it's later in a stage, DHE could be an option to try. The limitation to dihydroergotamine is that the patient should not have received triptan for 24 hours prior to the administration. Dopaminergic anti-nausea agents are important to apply. And then there's a data for dexamethasone, that could actually also help to prevent relapse, headache relapse. Ketorolac. We always recommend IV fluids, even though the randomized control trials haven't really shown a specific effectiveness, but overall, just to prevent dehydration, especially in a vomiting, it's an option to use. And then there's IV formulations for valproic acid, the Valproix that we use a lot, magnesium sulfate, acutely nerve blocks could be an option, and IV acetaminophen could be an option. This slide reminds that there is a lot of resources available specifically for the primary care physicians to American Headache Society, and the link is listed here. Again, with the understanding that over 70% of patients with migraine will see their primary care clinicians for this concern. In essence of time assignment, I will not be covering the rest of the primary type headaches, but I want to touch base upon other common issue with is which is a medication overuse headache, which is defined as in someone who has about 15 days or more headache days, and they are routinely using the medications that are typically used for acute abortive therapies. They're using these medications routinely for over 3-month period. It's common. It's 1 to 2% of general population. Medication overuse headaches can be easily masking the picture of the actual primary headache type. Therefore, it is important to recognize and address in order to be able to approach to main headache management better. So approach to treatment is there is 2 parallel steps to do. Early discontinuation of the medication that we think is causing the overuse, acetaminophen or any non-steroidal agents, and then adding preventive therapy to help to bridge and help with the headache control. Lastly, with the pandemic, there has been a lot of emergence of the headaches throughout the pandemic period, and there is currently defined headaches during acute phase of COVID-19 infection, up to 50% of patients. And then in post-acute phase, there's about 30% within the first month, and it gradually subsides to up to 16% at 9-month period. The characteristics of this pain were more common in female. The acute COVID headaches were more related to acute headaches were more common in younger patients, and post-acute phase headaches more common in older patients. People who have primary headaches, pre-existing headaches, they had more commonly headaches during acute phase, but there was no such association at 9 months. Really, the phenotype could be mimicking tension type headaches or migraine type headaches, so it could be in different ways. The approach to COVID-19 related headaches is really mostly symptomatic therapy, but there is some potential role to corticosteroids up to 40% of patients, and then great oxybutynin nerve blocks have been tried with success rate up to 85%, in addition to endomethacin short trials that showed over 50% response rate. For the preventive therapies, again, it's a small number of cases, but amitriptyline has shown some efficacy. And again, it's important to also approach the main headache type that patient may have as a pre-existing headache type. So in summary, there is a variety, large differential for headache disorders, and differentiating between facial pain and primary headaches is important to achieve accurate diagnosis. The secondary headaches will need to be ruled out. Therefore, looking for the red flags is absolutely essential. A migraine is the most common primary headache presenting to the clinician. The imaging of choice is brain MRI that can help to evaluate and rule out any structural causes for the headaches. There is a new emerging treatments for migraine that are migraine-specific therapies that can help to improve the quality of life and potentially reduce disability in a younger population. These are additional references that are not mentioned, and thank you.